This conference will now be recorded.
Did anybody have questions on that test?
That was a good test.
Hurry before she asks.
What is she?
Oh, I found it. So I
What is
found
she saying?
when it was talking about the muscular injuries on chapter 32, it says during the secondary assessment, apply a C collar. Wouldn't you do that in like the first things we're getting like a C size up? Isn't that like one of the first ones?
So yeah, they want you to consider C-spine, and if you need to hold it, you hold manual for the national history sheet. In real life, if you have a C collar right there, I would just run C-spine. Yeah, because you free up hands whenever you put a C collar on.
She's like,
I tell you what, you need to get you like some freaking yellow sticky notes just to like mark the pages of your questions.
I put a question mark next to like.
That's good though, because I always forget what question I asked.
Yeah.
Yeah, that's what I'm saying, so you don't have to sit there and flip and flip and flip. You just have the sticky note on the page of the question.
I know, I like hold my pages and still forget.
All right.
Yeah.
So, we have 2 chapters tonight. The head, neck, and spine chapter, we're going to be talking about trauma. And then the second chapter we're going over tonight, I was telling some of y'all earlier, I'm not going to lie to you. I really had to squeeze 11 slides out of it. I don't know why they didn't just combine it with another chapter. It's like, yep, multi-system trauma is bad. Drive fast. Go where they're supposed to go. That was it. So.
Yeah.
Anyways, this chapter's a little bit longer. I think this one's like 50 slides, but we tried to keep it interesting for y'all. So, our objectives: review A and P of the nervous system. That should be review. Review signs and symptoms of certain head and spine injuries. So, there's a difference between like a neurogenic shock and spinal shock. There's 2 different things there. They show 2 different presentations. So it is important to know the difference between the 2. And then cover nexus criteria and spinal mobilization. That should be reviewed because we went over it on Saturday. But this is just like the same slide actually, just talking about it again. All right, so brain, spinal cord, nerves. We have our central, and then we have our, I'm going to fix this because all I see is like, sorry, my astigmatism. All right, yeah, is that better?
Struggle with that too.
Yeah, this eye's bad. I can't see. All right, so we have our central nervous system, which is the brain and spinal cord. That's like the yellow and red parts on this little picture. And then we have our peripheral nervous system. So peripheral, if you think about like something peripherally, it means away from the core, right? So that's all of everything that reaches around. So part of our peripheral nervous system is our cranial nerves. If you hang around this station long enough with somebody that works here, Calvin Goddard, you're going to hear them talk about cranial nerves. So we have a way to assess cranial nerves through 2 through 12. We can assess cranial nerve number 1, but it involves like peanut butter or an alcohol scratch pad. But they all stem out from our brain. So they all do different things. They all have different functions. So if you ever want to make Calvin mad, just walk up to him and say, cranial nerves 2 through 12 grossly intact. And he's like, I start seizing. But this is all of them. I'm not expecting you to memorize them. And if you decide to go to A school, there is going to be, like, you're going to have to memorize those. But right now, don't worry about it. They might ask, I say that, and somebody's going to get a question on their NRMT, like, the vagus nerve stimulates what?
They're already asking questions.
Are they?
Yeah, medic test does.
Oh, so I should create.
Well, medic test also
PowerPoint.
throws stuff that's all the way up to paramedic in their test for some reason.
That's good though. Keeps you knowledgeable. All right, so nervous system have these little specialized cells. These are called our neurons. You don't have to, per our book, you don't need to like memorize all the different parts of the neuron. But it is important to know that these nerves are what transmit those impulses, everything through our nervous system. So if this is messed up in any way, whether it's like a poisoning, whether it's some kind of trauma, that's not going to talk to the rest of our body, and that causes problems. So Motor nerves, what do you think motor nerves do? Yeah, motor function, that was pretty simple, right? So, nerves of the autonomic nervous system control involuntary functions. So we have involuntary functions. What would be an example of that?
That's ones we don't have to think about.
Yeah.
So like heart pumping,
What did you say? Digestion, yeah. So, motor nerves are messages carried from the brain to the body. Say, hey, I want to pick up my water bottle. And your motor nerves are like, we're picking up the water bottle. So they control the voluntary movement. And they run across the opposite side of the body. So you'll run into that a lot, like if you're dealing with like stroke patients or trauma patients. If it's the right side of their brain affected, it's the left side that you're going to see the deficits in, and vice versa. So it's like everything crosses. And then our sensory nerves are what carry messages from our peripherals back to our brain. So if you touch something that's hot, those sensory nerves are like, hey, that's hot, and it tells your brain. So sensory from away to the brain, motor from the brain to the rest of you. So anatomy of the head, we have a bunch of different bones. As you can see, they're connected by these little fissures. These are important whenever it comes to like certain kinds of trauma to the face. We're going to get into some of like the Lefort fractures. So it talks about where the facial bones break and stuff. The easiest way for me to remember, like movable mandible, that's the one bone in your face that moves, movable mandible. And then this is your little TMJ, your temporal mandibular joint. So that hinge is what allows you to talk and chew food and all that stuff. It's also important to know the different parts of the skull, so frontal, temporal, parietal, occipital. If you're trying to describe to somebody an injury, you could say, you know, I felt crepitus or a boggy sensation on their occipital bone, so they can kind of get an idea of where it's at. Obviously, our brain is held within the skull. That should not be new information. I did want to point out on this picture here, it's kind of small. I have a better picture in one of the slides coming up. So our brain sits in this, right? This is like our cavity. It is not smooth. So when we're talking about damage to the brain, our brain gets bounced around in our head. Sometimes these bones that are like jagged will actually tear parts of our brain. So that's important to note, like when we're talking about coup contra coup injuries, because nothing's smooth in there. It's not like gliding on this nice little slide. So this hole that everything comes out of, where our brainstem comes up, is our foramen magnum. I just remember, because this might sound silly because I have some minors in here, but if there's a foreman on a job, they watch you dig the hole, right? Probably not, but that's how I remember. So foramen magnum. That's how I remember that. Is that what it is?
Yeah.
Well,
Being a supervisor.
yeah, so and then your CSF is kind of that cushion, that fluid that sits in your brain. It covers your brain, it covers your whole spinal cord. So what kind of tests do we do pre-hospitally if we suspect that there's like a CSF leak? There's some kind of damage in the CSF is coming out. I'm
Is it
seeing
the
it.
ears? Is that
Yeah,
what
it's
you're
really-
like,
Yeah, there's a halo test that we do. It's called a halo test. I have a whole slide about it. Yeah, so you stick a piece of gauze in and then hold it up and you'll see a halo sign. So, our spinal cord, obviously, goes down our spine, goes from the brainstem to the small of the back. This little bundle here, I'm not gonna say this right. Cauda equina, I think is how you say that. Something to do with a horse. I think it means like horse's tail in Latin or something crazy, because it looks like a tail when it's all, I don't know. But it does emerge from the end of the spinal cord. So this is like where your pelvis is, your sacral region, so right here where your pelvis meets your spine. And then the meninges surround the spinal cord inside of the spinal column. So if we have meningitis, that's what gets inflamed with these little meninges. So spinal column made up of 33 vertebrae. They're held together with ligaments. Does anybody remember what a ligament connects? And then each vertebrae has a donut hole. So this is our irregular bones, right? They're shaped kind of funky. I like this one. This is C4 because it smiles at you. If you hold it upside down, it's like a smile at you. My favorite vertebrae. And then they each have a spinous process. So whenever they're talking about the spinous process, they're talking about these little bones that stick out the ends here. So sometimes in trauma, those little spinous processes actually get broken off. Big ouchie. So does anybody remember how many bones are in each of these? We went over it during our anatomy part.
Breakfast at 7.
Dinner, snack after dinner.
Yes. Yes. So can this little server cook? So cervical is your C, thoracic, lumbar, sacrum, coccyx. So can this little server cook? Breakfast at 7, lunch at 12, dinner at 5, and tacos before bed. So 7, 12, 5, 4. That's how I remember them. How many are in each? And remember, your C spine 3 through 5 keeps what alive? Diaphragm keeps the diaphragm alive. So any kind of injury to C through 3 through 5 is going to affect the diaphragm. So scalp injuries. This is like the best picture I could find of this. I have a couple of them actually. But you can see all the vasculature that covers our skulls. So any little tiny.
So was that one.
That one actually might be in the PowerPoint too. Any tiny little nick or cut on the head bleed. Head wounds bleed a lot. So there's a lot of vasculature up there, and sometimes it can look a lot worse than it really is. It'll be like a tiny little paper cut, and there's blood everywhere. So keep that in mind. But if you're like trying to clean up the area and like all you find is a little tiny nick, don't be super surprised whenever there's like it looks like a gallon of blood next to it. If you have a skull injury and you're trying to dress it and you're suspecting that there's like a skull fracture or anything like that, I will say also in some instances, if there's brain matter coming out, please do not put like a hard dress, like a tight dressing on that, because I have firsthand seen where like the brain's coming out and I'm like, oh, can't let that come out. And we're like holding pressure and this guy starts to decline. And as soon as we get into the ER, we stop holding pressure and he's like fine now. So try and let things leak that are trying to leak out. That's super fun. All right, skull injuries. So you can kind of see where this is fractured across the top here. That's a certain kind of fracture. If anybody's watched The Pit, I'm pretty sure that they have a episode where the guy has a fracture like that in there.
Yeah.
So skull injuries include facial and cranial fractures. So anything from here up, that's all part of your skull. If it's an open or closed, remember this is like going to be our common theme of trauma, if it's open or closed. Same thing with your skull. You can have an open skull fracture or you can have a closed injury. So if you have like a good enough closed one, you can assume that something underneath is also broken. So like where they fell and hit their head pretty good, you can assume that there's going to be some kind of fracture up underneath that. You can't rule it out pre-hospitally, so just try and treat those wounds as if they were. Does that make sense? Okay. So direct injuries occur with open head injuries. So at this point, the brain is lacerated and can cause trauma inside of the skull. It can be caused by either that foreign body or it can be caused by those broken bones that are like jagged in there. This is actually a call that Chaz and I ran in Atlanta. This dude was shot twice in the forehead. He ended up walking out of the hospital like a week and a half later. But this was an open injury. His brain was coming out of his skull. It looked like a pimple. And we were holding pressure on it. And that's not a good idea. And then we have indirect injuries. So something like this, I would assume maybe he fell, hit the back of his head, maybe got smacked by a baseball bat. We don't know. But up underneath it, you can see where that fracture occurred. And then our brain is held in there, right? So does anybody remember like the 3 main fluids inside of our skull? and brain. So if there's a disturbance between any of those three things, it's gonna cause an increase of pressure inside of our head. Because if we have a increase of pressure inside of our head, what does it have to go out of to decrease the pressure? Yeah, the form of magnet, way down here, right? But what likes to occupy that space? Brainstem. So if there's any pressure put on that brainstem, you can actually start to see it in your patient in their presentation. We're going to talk about that. So TBI, traumatic brain injury, it just disrupts normal functioning of the brain. So it can be a short-term disruption or it can be a long-term disruption. So whenever we're talking about like somebody that fell and hit their head, it's really important to ask if they lost consciousness. Or if anybody around them witnessed them actually pass out, because that can kind of lead you to think of certain like brain injuries. So if they get a concussion, the head is struck, that force is transferred to their brain. What are some signs and symptoms you'll see with a concussion? Drowsiness, yeah. Headache,
Double
nausea,
vision.
vomiting, huh?
Double vision.
Absolutely double vision, ringing in the
I've had
ears.
7.
You've had 7? You should probably get that.
He's got the record.
Yeah, you should probably get that checked out. And then sometimes they'll have like an unsteady gait too. Like they'll try to be walking and they like kind of walk funky because their brain's messed up, right?
There's a video of me from the football game. I got a severe concussion. Testing doubles and I was walking all drunk on the field.
Good Lord.
It was awesome.
What's that brain thing that
I stopped.
Aaron
Hernandez.
No, we didn't.
Yeah, what's that called?
Yeah,
PC or something?
this
He had a lot of issues.
Yeah, what did you say?
CTE.
CTE? Yeah, that's it, right? Like long-term damage of the brain from multiple concussions. Yeah. All right, so then a contusion, what is a contusion? Bruise. So contusion to the brain is possible. So caused by a blow forceful enough to rupture blood vessels, you get a bruise on your brain. So concussion, mild injury, we talked about the signs and symptoms, mild headache, grogginess, short-term memory loss. Sometimes they can have a brief loss of consciousness. If there's any time that somebody falls and hits their head and they go unconscious and then come back, you should suspect, because we always suspect the worst thing, right? Kind of like with the abdominal pain in the female. You should suspect a brain bleed. So these people need to go get checked out. Contusion, unconsciousness, or decreased level of responsiveness. And sometimes that just doesn't come back. So if they fall and hit their head, sometimes it's like they pass out, they wake up, they're doing good, and then they progressively just keep getting worse because there's like bleeding into that brain or damage to their brain. What is this? What is this like a? Yeah, this is coup contra coup. Which one's coup and which one's contra coup? Yep, so coup is where it's getting smacked at, and then contra coup is where it comes back. I thought that was a cool little deal. I told you guys about these gifts. I wanted. So coup is on the side of the blow. So if the blow's on the back of the head, that's where the coup is going to be. If it's on the front, that's where it's going to be. So then you can have a laceration to your brain as well. That's what we're talking about, like these bones are jagged. These aren't like a nice little smooth thing. So if you imagine this, the brain's getting shifted back and forth, and this is not a smooth surface, so it starts to tear the brain. So then they start to get these brain bleeds, so hematoma, right? So we talked about hematoma, it can apply inside your head as well. Here's another example of it. So you can see where he got hit in the back of his head here, and there's bleeding or blood pooling up underneath those little bones. And then here's the picture of that brain. So there's blood all up underneath. This is the bottom half of the brain. So you can see where that bleed was, that laceration. I'd say he's there. I don't think that they take the brains out if they're not. I don't know. That would be a Calvin question.
I'll say no. How do you think these folks present to you? Like in what manner would this patient present to you? The easiest way to look at a lot of these is they would present very similarly to like stroke patients, especially when they start getting this hemorrhage in their brain. They're gonna start getting deficits. So like Becca was saying with the call that we ran, where we were like holding the guy's brain in his head, because we were like, freaking brain. And we were, I mean, that's the first time we had ever seen that, right?
'Cause they
Somebody that
teach
was
you-
awake and talking to
Yeah, they
us.
teach you in school, like, brain matter is obvious sign of death. But then this guy, I'm looking at this guy's brain matter, and he's sitting here trying to communicate with me, I'm like, he's not dead, he's not dead.
And so essentially, we inadvertently gave him a stroke, because what we saw progress was his heart rate started dropping, he started getting deficits on one side of his body, stuff like that. So these can present very similarly to a stroke.
Altered mental status, deficits, like one-sided deficits, especially if it's just one side of the brain affected. If you have like altered mental status after falling and hitting their head, especially if they're on blood thinners, these are all patients that you need to be careful for. So here's our little layers of the brain. So here's our skull, it's the bone, and then here's our meninges. So dura mater, fun fact, means tough mother in Latin. That's cool. Arachnoid, and then pia mater, and then our brain here. So depending on where this bleed is depending on what they're going to call the bleed. So where it is in each of these layers. So epidural hematoma or subdural is between the brain and the dura. So here's the dura. It's going to occur somewhere in between these layers here. Then you have your epidural is between the dura and the skull. So it's going to be up here above these. And then your intracerebral is just going to be inside of your brain. So if you break that word down, intracerebral, intra meaning inside, cerebral meaning brain. It's in there somewhere. So whenever you look at like CT scans and stuff with people's head with like head bleeds, and they have a really bad head bleed, you'll see this is their midline. You'll actually see it shift. So if you have like a midline shift, that's bad news there. So at this point, these may present like a stroke. At this point, they need surgery. So if you have a hospital and you're suspicious of a bleed, you need to take them to the appropriate hospital in a very timely manner. So ICP, intracranial pressure. So we talked about inside that skull, there's nowhere else for that swelling or extra fluid to go. So it starts to go out the bottom of the skull, right? So this is kind of like a development process. And as this happens, it could be short or it could be fast. But there's different signs and symptoms that you should be looking for. So as it builds, the ICP gets worse. As ICP builds, brain tissue compresses and neurological abnormalities develop. So specifically, whenever we're talking about towards the foramen magnum, it's starting to push that brain back out that hole, because that's the only place that it has to go. But we talked about what sits right here, right? What is that? Brainstem. What is our brainstem in control over? What is it? Breathing, vitals, yep. So ICP increases, perfusion decreases because it's all getting squished. CO2 levels increase, brain tissue swells, and then as this grows, this swelling on the brainstem is going to get worse. So our patients with this are going to present with a certain set of symptoms that we call Cushing's triad. Like I said, there's going to be lots of triads, but Cushing's triad is what they present with in like an increased ICP. So the first thing you're going to get is hypertension. So hypertension, what that is doing is their body is telling the brain, like, hey, we don't have enough perfusion up here. You need to amp up that pressure. So that blood pressure is going to shoot through the roof. Their blood pressure goes high because it's pressing down on their pons or their brainstem. They're going to get irregular respirations. These can present multiple different ways. They call them, there are different names for them. So the most common one that you're probably going to be tested on is Shane-Stokes or Shaney-Stokes. I don't know how to say that. I've heard it both ways. So irregular respiration, but that doesn't have to be Shane-Stokes respiration. Sometimes it's ataxic, sometimes it's like periods of agonal, and then they start breathing really fast, and then periods of agonal. So Shane-Stokes is like they breathe shallow, and then they start breathing really deep, breathes shallow, and then they have a period of apnea, and then it does the same thing. So it kind of like amps up to like taking huge deep breaths and then comes back down. Does that make sense? All right. And then the last part of our Cushing's triad is a heart rate. So our heart rate will actually slow down if you have increased ICP, because it's putting pressure on one of those cranial nerves called your vagus nerve, and that vagus nerve innervates our heart. And because that's getting pressure on it, our heart isn't like, oh, speed up. It's actually telling our heart to slow down. So if you ever have a patient with altered mental status, high blood pressure, irregular respiration, slow heart rate, you should have all of the little signs going off in your head like, oh, brain bleed or something like that. So, like I said, these can be like a progressive onset, or this can happen immediately depending on what's going on inside of their head. But it's really important that you are able to identify these three signs together and what they mean so you can get them to the most appropriate facility. And then, this is the worst part of it. So as that brainstem herniates, they start to posture. So this is a reflex. So sometimes I've seen patients that they have increased ICP and their brainstem's damaged and they're just laying there. As soon as you try to do any painful stimuli, they'll start to posture and then they relax. So this isn't present like constantly all of the time. I've seen it where it is and I've seen it where it isn't. So that's important to note. So decorticate is towards the core. Decerebrate is away. Decerebrate means they're flying to Jesus. That's the worst of the two.
We covered that during the GCS.
Yeah.
That's going on.
Yeah, that's part of your GCS scale. So if you ever have to calculate a GCS, that is part of it. All right, so basilar skull fractures. Everybody has learned the fun little battle sign, raccoon eyes. This is where those fractures are in the head. So usually they're like a linear fracture, and that CSF fluid starts to leak out the ears, sometimes the nose, sometimes this looks like it's coming from the mouth, but I think it's coming from the nose. But they have a CSF fluid leak, and that CSF fluid sometimes is mixed with blood, so it can be kind of hard to see. So you can do that halo test with a piece of gauze. That's what it looks like. As soon as that CSF and blood hit the gauze, they separate. And so if you hold it up to the lighter, you can just see it here. There's a ring around it. And then here, this is actually a patient that Chaz and I had that was shot in the back of the head. He had blood coming out of his ear. I was like, oh, I should probably check for a halo test. And then I look at the sheet and I was like, I don't have to. It's already done for me. So you can see here where it separates. He lived too. That's not the same guy that was shot in the head. It's a different guy with brain matter. And he lived too. So we had two patients that were like, you should be dead, but they weren't.
Unfortunately, the patients don't read the textbook. Kind of sucks. I wish they would. It'd make my life a lot easier.
Yeah. Because this one, the call came out as like an obvious dead person in a car accident that it was shot at. And so we pull up and the cop's like, you need to get over here. And I was like, is he dead? He's like, hurry up. I was like, is he dead? She goes, he's talking to me. And I look in the car and his brain matter is like splattered on the roof and then like on the steering wheel. And I was like, okay. And then he looks at me and I was like, we gotta go. It's time to go. It was kind of eerie.
It make your butthole go.
Yeah.
So when it's lost brain matter, is it
Yeah. So this
the
patient.
same person after?
Yeah.
Well,
That's
there
awesome.
have been studies that say brain injuries can alter the personality of a patient depending on where the brain injury is. And so, like, that's where you see the studies of, like, those frontal lobe tumors and, like, all of a sudden people go off and, like, kill their whole family and all this other stuff, and then they biopsy them, and, you know, they got this giant tumor sitting somewhere in their brain. We never talked to these two patients, so I actually have the same 3D reconstruction that we had on the other patient. I have one on this guy, too. His kind of scraped, started at the back of his head and kind of just took out a big chunk of his skull. And then the other one kind of looked like a bad drug deal. And the guy, like, because there was two people shot at the other one was shot in the stomach and the arm. And I think when the guy come in the door and started shooting, he ducked. And when he ducked, he got two to the top of the head, right around the forehead. But both times, they were completely with it. GCS is a 15. They couldn't talk, so I guess their GCS was slightly altered, but they were with it enough to where if you asked them how old they were like trying to sign language you and talk to you and stuff like that. They just didn't have the physical ability to actually communicate with you. This one had a little bit more of it because Becca was like, he looks like he's like 25. And the guy was like, yeah. Becca was like, huh.
It's one of those, like, I called him report and like, call me back when he codes, and then he never coded. I was like, I don't know what to tell you.
That's horrible.
Yeah.
Yeah.
So these are those Lefort fractures that we were talking about. So the different fractures of the facial bones. So they classify them in 3 different classifications. So Lefort 1 goes across the nasal bridge here. And then Lefort 2 comes up across the eyes and then back down. And then Lefort 3, the worst of them all, goes across here.
Have you ever seen the 1, 2, 3 for this? To make it easy to remember? So I actually learned this one time. This is the only time that I'm going to be helpful.
You have to hit.
There's a guy on YouTube that has this. He says it's like building a sandcastle.
So
Building a fort. Yeah.
I learned this a while back too. So if you look at the Lefort 1, it goes kind of like that, right?
They can't see it.
Yeah, we'll take a picture of it. I'll send you a
Okay.
If you look at the Lefort 2, it kind of makes this like almost 2 shape right over here. And then if you look at the Lefort 3, it makes a 3 right there around the eye sockets.
Oh, that's cool.
That is pretty cool.
That's good because I can never remember them.
That's a good way to remember that. It kind of makes a 3 right there around the eye sockets, but that's how to decipher them because you get the 2 that kind of comes up. 1 goes straight across, 2 goes like that, and then 3 is like right up here around the eye sockets. So you want to take a picture of it?
I think you can save it, but I don't know. All right, cool. Okay, so pain, discoloration, any kind of fracture, signs and symptoms, but to their face. So swelling of the jaw. Sometimes if you like suspect that someone had good facial trauma, you can ask them when they put their teeth together if it feels normal, because they've been dealing with their teeth the whole life. So if there's any kind of misalignment of the jaw, they'll be able to tell you like my teeth are crooked. And unless you point it out, sometimes they don't even realize that's what's going on. So that's a good assessment tool. All right, so if you're going to treat a facial injury, this is what we're talking about, like the teeth being separated. Ooh, I hate teeth. Teeth things just give me the ickies. So be prepared to suction. If your patient is alert and oriented, I've had patients that come in that they have bad facial trauma, and I'm like busy doing other things, but they're with it enough that I just hand them a suction and like, hey, suction out whenever you need to. Sometimes they're like alert enough to do that. If you can control profuse bleeding, if they have like major bleeding on the inside of the mouth, sometimes you can line the inside of their mouth with some gauze and like hold pressure on the outside. Sometimes that'll help. Sometimes you just can't stop the bleeding, right? Because it's like in there and you're trying to do airway stuff and you're just suctioning. But we use gauze, like rolled up gauze, stuck it in like where the tooth got knocked out or something and it's bleeding, those kind of things. Anytime there's trauma to the head or skull, you should suspect like C-spine damage as well, because our C-spine is not well supported compared to like our thoracic. So keep that in mind if they have good like blood trauma to the face or the back of the head. That's something that you should consider. And treat for shock. All right. Signs and symptoms of skull fractures or brain injuries. They have one eye that appears sunken in further than the other one. I've had patients that it looks like that, and then I look at their driver's license, and that's just what they look like normally. So keep that in mind. Driver's license pictures are great reference points, especially for like stroke people. Like, is this normal for them? When you look at a driver's license, yep, it's normal for them. Cushing reflex. So that Cushing's triad is also called Cushing reflex. Personality change, that's what Chad was talking about. If it's your frontal lobe that's damaged, it can affect your personality. So different parts of your brain affect different things, right? So we have a whole area of our brain that's dedicated to understanding speech and being able to talk, called our Broca and our Wernicke area. So if you have an area of that area of the brain is affected, sometimes they are trying to talk to you and some crazy stuff comes up. Like they'll be like, oh yeah, the pink banana hammock only flies on Tuesdays. And you're like,
Yeah, it's freaky.
what do you say?
Yeah.
But they think that they're just saying wrong words. So blurred vision, impaired hearing, or tinnitus. What is tinnitus? Yeah, ringing in the ears. Signs of shock. What kind of shock specifically? Neurogenic shock. Equilibrium. What does that mean? Yeah, their balance is way off. Forceful or projectile vomiting. Especially if brain bleeds for some reason, like in comparison to like a ischemic stroke, if you're dealing with like a hemorrhagic stroke, for some reason they just love to like projectile vomit everywhere. That's like the major sign and symptom that I've seen for that. Posturing, what does that mean? Before you get decerebrate, good. Paralysis or disability on one side of the body. So these are our neurogenic symptoms. So they have like tingling, numbness, loss of pulse, anything on one side of the body. That's something to keep in mind. Seizures, TBIs can cause seizures. You know that one. Hyperthermia. So we have our little hypothalamus in our brain controls our temperature regulation. So if that is affected, they can no longer control their body temperature. So hyperthermia is one on that little list. So your treatment, obviously, we decided routines, blah, blah, blah. ABCs, consider C-spine for those patients. Apply cervical collar if it's indicated. So we talk about that nexus criteria. We're going to go over it again. If they are like severely altered, they have brain trauma or suspected brain trauma, you should be putting them in a C-collar. Control bleeding. Obviously, you can't control bleeding on the inside of the head. So that's why that little asterisk is there. And then stabilize any impaled object. So if they have an impaled object, remember we never want to remove it unless what? There's like certain things why we remove an impaled object. Everything there, we're in another one. Can't transport? Okay, one more.
Was it?
Staying alive.
Yeah, if it gets in the way of CPR, it needs to be removed. Keep them at rest. If you're suspecting increased intracranial pressure, try and keep their head in an inline position. So that's one other thing that a cervical collar is going to do for you, because if your head's like tilted off to the side, this has never been like fully proven, but they teach it. If you put a C-collar on, it helps those like jugular veins drain and it keeps the pressure away from their head. Is it going to do is it going to be a life-saving intervention? Probably not, but we're trying to get these patients to a little bit better off than they were when we got there. Be prepared for vomiting and then vital signs every 5 minutes. Here's that Glasgow coma scale that everybody loves. So this was actually invented for traumatic brain injuries. And then EMS saw it and they're like, cool, we're going to apply it to every single patient. But this kind of tells us like the level of the injury to the brain, depending on what their level is. So I remember the eye opening. If someone wears glasses, they're called 4 eyes. Yeah, 4 eyes, 4 points. Verbal response, if you say talk to the hand, you have 5 fingers, hopefully. So that's 5 points. And then for motor response, I remember like 6-cylinder engine. That's how my brain remembers it. So there's 6. So that's each of your points. So if you have somebody without a brain injury, most likely they're not going to have this abnormal flexion and abnormal extension. That's that decorticate and decerebrate posturing that we're talking about. The easiest GCSs to calculate are 15, 14, and 3. Because if they're just confused, that's 14. If they're only alert to verbal, but they can sit there and tell you exactly who they are, what's happening, and then they can give you a thumbs up. If you tell them thumbs up, that's 14. And 3 is none, right? So 3 is the lowest you can go. So you're going to sound real goofy, and I've done it, being like, oh yeah, they have a GCS of 0. It's not a thing. Three's your lowest. Injuries to the neck. I showed y'all this video the other day, so I didn't put it in here. Well, I did kind of. I could click on that and take over the video. Did everybody see this video? Yeah. No? All right, we're gonna show it. Let's hope it works. Hopefully it takes me to it. Okay, that's fine. I understand. It wouldn't let me just upload it to the PowerPoint because it's inappropriate or something. That's what I said.
Kept it by Bodger. There's a long shot. Rado makes the save. Loose puck in front. Meanwhile, jumps to the rebound, but it's stopped by the left pad. Here's Bodger sending it back in front now. Comes back to the line. Kept in by Crew. Now recovered by Motter. Gets it back over the line. Here's the pad. On into the Buffalo zone. Mahar goes to the corner of the pass. And oh, wow! That'll watch Mahar, Chuck. That's the story right now with look in. That is the oh, God.
All right, Steph. You go watch your hockey game next week.
Oh my God.
You got to jump out there on the ice and save it. You jump out on the ice. I am an EMT school.
They're like,
Get out of here.
Yeah. So that is a bad day.
Is that a skate?
Yeah, Skate's got his neck.
oh,
This guy got really lucky though, because he had an old combat medic that was there that basically just walked up and pinched off that artery and just held it. And otherwise, he'd been dead in like 2 or 3 minutes. If they would have waited on the EMS to get there, he'd have been dead.
Oh, yeah. Yeah, for sure.
so
Okay,
Hmm?
so injuries to the neck. How are you gonna treat them?
the red.
Direct pressure with a gloved hand. Okay, what next? Say that a little bit louder. Yes, how are you gonna do that? With something, like an inclusive dressing, yes. So, obviously, if it's something like this and someone's like holding it, I'm not gonna stop them from holding it. But if you have an injury to the neck, we have a lot of vasculature here as well. So, large arteries and veins close to the surface of the neck. So you can see them in some people, like singers, they're singing, their little singing vein pops out, they're close. So basically the pressure on the inside of the veins here, because of the size of those veins, they're gonna wanna suck air in. So if that air gets sucked in from the outside, it can cause an air embolus, which can kill the patient. So that's why we're putting on that occlusive dressing to stop that bleeding and also prevent outside air from getting inside of those arteries and veins. The one time I've ever seen this done, we put an occlusive dressing on, and I actually, not me, my paramedic partner, put a C-collar on to hold that occlusive dressing in place, and then we drove real fast. So obviously it can lead to death. So here's an example. So direct pressure with a gloved hand, emphasis on the gloved hand, is NREMT. So priority number 1, if you're pressing too hard, don't interfere with their breathing. Obviously, you're not helping anything at that point. So priority number 2, once you get the bleeding a little bit under control, do that occlusive dressing. So we have large tapeworms that you can use for this. You can use that gauze stuff, the plastic packaging or the metal plastic packaging from that gauze stuff that we have. Whatever you have that's not going to let air go in and out of it, basically. So, injuries to the spine. Ooh, that's a bad day. You can see the spine's like, see you later. That's a bad day too. So, bones, ligaments, and cartilage is our spinal column and what it's made out of. So if it's damaged, the spinal cord may also be damaged. So sometimes they're not displaced like that. but there's enough trauma to that area that the spinal cord and like meninges and everything starts to swell on the inside and actually start to put pressure on it. So you might see some neurological symptoms from that. That's what we're talking about, the fractures with or without bone displacement. Not everyone with a broken back, you're gonna feel like they have a step off. Not everybody has that. Sometimes it's in there, you can't see it, they need an x-ray. Sometimes, you may have, like if you were to feel this, sometimes you don't feel step offs, right? So that's why it's important to do those assessments on everybody so you can start feeling when abnormal is present. And then we have our disc injuries, so you can get the lower compression injuries to our discs on our spine. That causes a lot of pain. If anyone in here has ever dealt with a back injury, they know how painful back injuries are.
Are we gonna put this patient on a backboard? Absolutely, frick not. So you see where that break is and see all the stuff it's pushing against? If you put them on a long spine board that's really hard, all you're gonna do is make that situation worse for them. Be mindful of that. Try to keep them in a position of comfort in line, but just be mindful of that. That's what it looks like, and that's what you're putting them on. And if you put them on those hard, rigid backboards.
So the biggest point to take away with like spinal immobilization is just don't like grossly move the patient. Like don't start yanking them. Don't grab their head and start to roll them without the rest of their body. Don't like mangle these people up, because if they do have something like this, the chances of you just by moving them like nicely to a backboard compared to like if you were just jostling them around, the chances of you causing more damage is pretty slim, because at this point the damage is already done. So we're just trying to prevent further injury, but by maintaining that inline and anatomical position. So different kinds of injuries, we have flexion and extension. So the whole whiplash maneuver, over rotation. So sometimes you might twist too hard, twist and go to lift something. Compression is that shallow water diving situation where they dive in, hit head first, the axial load.
They love to put that on tests.
They sure do. Yep. And it's always them diving into the shallow end of the pool. I don't know why they don't think of any other scenario but that one. Penetrating trauma is one thing to think about too. If it's already done like directly to the spine, we talked about those bullets moving. If they have like a penetrating injury directly to the spine, like we said, that damage is already done and the chances of you causing further damage is pretty slim. So be mindful, be gentle, but don't like take them down to the backboard and be like, I fixed them, because that's not it. So we talked about this. Cervical and lumbar don't have any supporting structures on them, like the ribs, so they are more susceptible to injury. But then there's also people with different medical conditions that are more susceptible to injury as well. So like osteoporosis, which is what? Yeah, like a brittle bone. Yep. Ligament laxity in pregnant women. So pregnant women in their last few weeks of their term, they actually secrete a hormone that makes their ligaments more bendy. If anyone in here's been pregnant before, I've never been, but I've had people tell me like as you're walking, you can feel like your legs a little bit more bendy. It allows them to give childbirth, like your pelvis to expand and all that. So the pregnancy patients later term, they are more susceptible to damage as well. And patients with Down syndrome, they just have different kinds of, what is that, their C1 is like different? Do you remember, Chad?
The what?
In Down syndrome, is it C1? Their C1 vertebrae is affected?
Oh, I can look it up.
Yeah, look it up. I want to figure this out. And then fused vertebrae, so whether that's from like a surgery that they've had, it's ankylosing spondylitis. I hope I said that right. You can see where it starts to like compress together and form together here, where there's normally a space.
C1 and C2.
Is C1 and C2? Okay. So they're more prone to like C-spine injuries because of that. They're also harder to innovate because of that. Here's that nexus criteria. So they talk about this in the book. We talked about it a little bit on Saturday. So midline posterior meaning in the back, right? Spinal tenderness, so if you feel down their spine and they're like, yep, that hurts on their spine, that's criteria for this. Painful, distracting injury present, what would be an example of that? Yeah, broken bones, like obviously broken bones. Intoxication present, not if they smell like alcohol, if they have other signs and symptoms of intoxication, like your altered mental status, that fun stuff. Neurological deficits, that numbness or tingling, loss of sensation, any kind of neurological deficit you should suspect. And then encephalopathy, which is just means altered level responsiveness. It's some kind of dysfunction in your brain causing abnormal reactions. Here's that Canadian C-spine rule. This one differs a little bit because they added the age, and then they kind of go into more detail of like dangerous mechanisms. Our next chapter really goes into dangerous mechanisms.
Do you know what rule Renown uses for their trauma criteria? I know this is very, very similar to what Grady used.
We did use this Canadian.
Yeah, I think they changed a couple of things in it though, because like pregnancy. Is pregnancy in here? No. So there's a couple of differences, but this is like one of the more common ones that you'll see is the Canadian C-spine rule. So
Yeah, it's good to know what trauma center you're bringing up to and what criteria they follow. Just because if you get into like these bigger cities and busier cities, they will triage you before you walk in the door. So you know what to say, like, hey, this person's 65 on blood thinners, altered mental status, and has neurological deficits. And they're like, yep, that's priority 1, go here. So it's good to know these depending on where you work.
out here it don't matter, you just fly.
Yeah, flying.
Fly them all.
Hopefully. So assessment must account for possibility of spinal involvement. So any traumatic injury, we already know this as you're going through your little sheet, your first thing is consider C-spine, right? And then not every patient has a spinal injury. So these are suspected spinal injuries. Is the mechanism there? Are there signs and symptoms there? If somebody was walking and stubbed their pinky toe, am I going to do this full assessment on them? Probably not. If they stubbed their pinky toe, grabbed their foot, fell off the top of the building, would I do this assessment on them? 100%. So low risk, low energy mechanism of injury poses as low risk for any kind of spinal injury. So we're talking about low risk, low threat injury. Your very minor MVCs, like you go and look at the car damage and they didn't even knock the dust off of somebody's car and they're like, oh my back. Hey man, can you walk to my stretcher? Like that's a different thing. And then geriatric spine fractures. Our geriatric community, just because of the osteoporosis, underlying health issues, that kind of stuff, their bones get more brittle with age. They are at a higher risk for spinal trauma. Also, patients that are on long-term steroids can also have they're more susceptible to like injuries to their bones. So high degree of suspicion, our criteria for this, if you're looking at like pedestrians versus vehicles, motorcycles versus vehicles, ejections, big things, right? Look at your vehicle whenever you're going on an MVC and you'll start to see like patterns of like, oh, this person's pretty messed up and this is what the car looks like. Yeah, so blunt injury to the spine or above a clavicle, that's a high degree of suspicion. So that can mean a multitude of things, right? So baseball bat to the back of the head could be one. Getting in a car accident and hitting their head on something. All right, so here's our little dermatomes. So each of our little nerves in our spine innervate parts of our body. So this is the front and this is the back. So if we have spinal damage, say this C3, C4, C5, they innervate our diaphragm as well. But sometimes you can have where like T9 is damaged, like down here, and their spinal cord's damaged. So from this point, T9 down, they just lose all function. Their vessels stop or constricting like they should, so they get like dilation because their brain is no longer able to communicate from this point down. So that goes for any of this. So whenever we're looking at suspected spinal shock, is something is severed in here. So what kind of signs and symptoms do you think you're going to see with a spinal shock patient? Paralysis. There could be a difference in temperature, like skin temperature from one to the other. Because think about it, their brain isn't like, hey, their brain forgot that that part of their body was there. So there's no kind of regulation there. So if everything dilates, what kind of signs and symptoms are you going to see? Hypotension, absolutely. So low blood pressure. But if their brain's not connected to the rest of their body, do you think their heart's going to be like, oh, we're struggling? Do you think their heart's going to speed up? So what you'll see with spinal shock most of the time is hypotension because of that vasodilation. And then you're also going to see like a regular heart rate. And it'll throw you off because you're like, this person needs to be compensating, but they're not even trying. And it's because their brain doesn't know that this part of their body's not working. So paralysis, hypotension with or without tachycardia, depending on that level of injury, is if you're going to get tachycardia or not. Neurological deficit, so that numbness, tingling, sometimes it can be bilateral, sometimes it's unilateral. Their breathing, if it's affecting their diaphragm, they're just only going to have their little intercostal muscles to help them breathe. So they'll be taking really shallow breaths. Priapism, we all know what that is, sad boner. Loss of bowel and bladder is another really big one. So if you're doing an assessment on a patient that was involved in an NDC and they lost their bowel and bladder and they have another one of these symptoms, that's something to be on high alert for. Sometimes people just pee themselves because they're scared. That's a thing too. So keep that in mind. So we talked about this on Saturday. I'm going to touch on it again. It's going to be real to your head by the end of this class. We don't backboard everybody all the time anymore. There's a time and a place for a backboard. Okay, so lung injury, if they have any compromised breathing, you're just going to make it worse by laying them flat on a hard surface. These boards don't warm up, they stay cold, so that includes like our little hypothermia patients that are trying to keep warm because of the trauma triad of death. We're like, let's stick you on this cold board because it sounds like fun. And then also pressure sores, especially in the older population, but the study that they did was on healthy 20-year-olds and they were still getting pressure sores. So the only time I use a backboard is to bring the patient from where they were injured to my stretcher and then I take them off of it. So treatment of a spinal injury, you're gonna hold manual stabilization of the C-spine. You can apply a C-collar. I know in your book it says secondary assessment is when you apply the C-collar. In real life, I'm gonna free up a set of hands and put the C-collar on, so I don't have to sit there and hold them while we got other things going on. Treat the ABCs and any major life threats. What falls in this category, especially with trauma? Major bleeding. Any patient with neurologic symptoms should have a BGL obtained. Unless you know for sure and are 100% positive that they didn't have this traumatic episode happen to them because of a hypoglycemic emergency, you should be checking this. Limit movement of the spine. Like I said, don't sit there and start jostling these people around, but keep them in an inline position. Sometimes if you're moving them with a mega mover, be like mindful of that. And then if you roll up on a patient and their head's like out of a natural position, like they're laying there like this, grab their head, put it in anatomical position. Unless you meet resistance, you just want to keep it there. If you meet resistance, try and like splint it, stabilize it like this. But I've never ran into that where I'm like, their head just won't move, or it's too painful for them to move. Yeah. And then account for natural curvature of the spine. So whenever we used to really pound in on the backboarding, they would say pad the voids. So where our spine like curves here, you put a blanket there or pillow. Same thing with behind the knees, between the legs. So account for that. That's why the stretcher that we have in the back of the truck is the best bet for them because it's the most comfortable. It's the soft. And then make sure you're assessing CMS before and after any kind of movement, any kind of splinting, any kind of spinal immobilization. Make sure you're checking CMS. So we have 3 centers of mass: our head, our torso, and our pelvis, our shoulder girdle, and our pelvis. So the big point of this slide is that if you are moving a patient and you're considering like spinal immobilization, don't move any one of them apart from the other one. They're closing out their standby from earlier. All right. Yeah. So if they're maintained in a position of function, that's what you're going for. Whenever we say position of function, same thing with splinting. You want to keep it in anatomical position. So if their neck's like this, that's not an anatomical position. You want to put them back midline. So steps, manual, hold their head. I seen y'all doing that on Saturday when we were doing our scenarios. Y'all did a really good job of that. Place the C-collar, make sure it's properly applied. We went over this as well. Make sure you're measuring it before you put it on the patient. Make sure it fits them correctly. If they start complaining of difficulty breathing after you place it, maybe you could reconsider your placement. And then check CMS. So per your book, this is when to use a backboard. So when transport time is short, for me, I don't take that into consideration because even if your transport time is short, they're gonna leave them on that backboard in the ER until they clear their C-spine, or most of them are, most hospitals will. So even if your transport time is 15 minutes, there's still a possibility that that patient's on the backboard for another hour at least. So I keep that in mind. Sometimes if they have multiple injuries, I've had patients with like bilateral femur fractures. Sometimes it kind of helps you splint like those bones. If you have a lot of broken things, it kind of holds it all in place for you. Out here, we actually have giant air splints. They're the size of a backboard. If I run into a scenario like that here, I'm going to use that rather than a backboard.
Throw it.
Yeah. If the patient's going to need CPR, this is like that hard backboard that we put behind the patient that allows us to do better CPR. So that's a thing to keep in mind. And then if you're going to move them from the backboard to the stretcher and it's going to cause excessive movements, you're supposed to leave them on the backboard. I've never ran into where this is going to be a problem in 10 years of doing this. You can remove a backboard from somebody in like one fluid motion. So if that is a case, I can't think of one in my head. If that is a case, don't remove them. Contraindications, respiratory distress, and conditions that impact breathing. Another wonderful advancement in medicine is our scoop stretcher. I love a scoop stretcher. There's a picture of it right there. Yeah. So it scoops. Scoops your patient. These ones aren't so bad. The metal ones will pinch the crap out of your fingers. So be mindful. This just clicks, pick the patient up, unclick it, and then they're on your stretcher. Amazing.
You gotta be careful not to pinch them.
Yeah.
Real
These ones
careful.
aren't bad, but the metal ones are.
Yeah.
And then if you have a vacuum mattress, that's that big air splint that we were talking about. She's on one here too. See how it's like accommodates to her curvature? The downside of this is sometimes they can get like an air leak and they'll go like back to where they were before you get to where you're going. So keep that in mind if you're gonna use it. So seated patients, we used to use the KED right here. This is called a KED.
This used to be part of the National Registry Skills Test too.
Yeah, so those sheets that you have, the National Registry sheets, there used to be one, especially for this. And so if you walked into the National Registry test day, there was a chance that you were gonna get tested and putting somebody on this thing. I've used one once in my 10 years of doing this, and I actually used it as a pediatric backboard to like help extricate. I didn't even use it for what it was used for. So the idea of them is the patient sitting there, you're suspecting a spinal fracture, they're in the front seat of a car or a back seat or wherever they're seated in the car, and you keep them in a seated position to immobilize them, and then move them onto the backboard and then strap them to the backboard. So, they don't really teach these anymore. We're gonna show them to you. I'm not gonna test you on them, just so you can see what they look like. Because there might be a time and place where you might use one, you need a MacGyver or something. If you're suspecting spinal injury and they're seated in a car and you're trying to extricate them, the best way to do that is just slide the backboard up under their butt and then like slowly rotate them down and out and then onto your stretcher. If the patient is not really having like any major symptoms and they don't meet that nexus criteria, hey buddy, can you stand and sit on my stretcher? I do that all the time, unless they're like completely altered or like can't move their left foot or something crazy. That is perfectly okay. If you get on scene to a car accident or a rollover or whatever, and the patient's up walking around, don't be like, sit down, I need to strap your back. Because if they're up walking around, most likely they don't have any kind of fracture. This was on your slides, so I just put it in there with extra stars, just to kind of drive a point home. We also have a short spinal board. I thought I had a better picture of it in there. This is it right here. It's shaped like this. You can also use that if you feel the necessity to use it. So basically, you just strap your patient in like they're wearing a backpack. Hold their whole spine straight. I've never used one of those in the field. So.
I would judge you if you did.
Maybe.
So we'll go over taking a patient out probably next Saturday. Next Saturday we have class. We're going to go over some of this stuff, and part of that's going to be taking a patient and extricating them out of the vehicle from a seated position and onto a backboard. And you'll see, like, there's not a lot of spinal movement as long as you do it in a pretty fluid motion. There's not a lot of movement in that process, so these are very, very unnecessary.
Yeah. I've also talked with a couple people at the station. They're going to bring in some helmets if y'all want to bring your helmets in too, and we can go over this that Saturday. So if somebody's in a helmet and their airway, if you're suspecting spinal injury, the only time you should remove a helmet is if their airway is involved, if you can't assess their airway, or if any kind of resuscitation is needed. So in theory, you should just leave the helmet on until they get to the ER. Most patients hate that. Please take this off of me. So if you're gonna remove it and you're considering like cervical spine or any kind of spinal damage, this is how you should do it. It should be a 2-person job. You have one person that goes up underneath the helmet and holds their head, and then the other person's gonna pull it off. Sometimes like football players and stuff, they have those big pads. If you're immobilizing somebody with big pads and you choose to take the pads off, you should take the helmet off as well. It's both of them or none of them. Yeah, so if it fits snugly, that's another thing. If it's like huge on them and it's the wrong size helmet, obviously you're gonna remove it. If it fits correctly, there's no possibility of airway problems. You can assess the airway okay and they don't need resuscitation, you can leave it on. All right. I need one person.
Dun, dun, dun.
Alyssa.
Dun,
I
dun,
I always
dun.
pull your name first. All right, case study. You're dispatched to a 65-year-old male involved in a motor vehicle accident. That's what his car looks like. Your patient is found sitting in the driver's seat with a hematoma on his forehead. He is noted to be incontinent to urine. He is semi-conscious, and vitals are as follows. Heart rate is 62. SpO2 is 88% on room air. Respiration is 12, shallow with intercostal muscle use. His blood pressure is 88/52. His temp is 99.1, and his blood sugar is 98. What kind of shock is this patient in?
decompensated?
It
Is that
is-
what kind you're talking about?
It is decompensated. What is
Okay.
the origin of the shock?
Neuro.
Okay, what specific off branch of neurogenic shock is it? So he has an injury to the top of his head, right? He looked at his car. I'm suspicious that his head hit that windshield, right?
Yeah.
Causing an axial load to the top of his head. We're concerned about the spine, right? He's semi-conscious, his blood pressure is low, but his heart rate's not compensating for his blood pressure. Right? So it is a little bit different than neurogenic shock. He's shallow with intercostal muscle use. So remember, if someone's not breathing with their diaphragm, how do they try to make up for that?
I don't know.
They use their intercostal muscles. So we use our intercostal muscles and our diaphragm to breathe, but if the diaphragm's gone, all you have is intercostal muscles. It's shallow. He can't take a deep breath because you don't have his diaphragm anymore. From when we go back to our dermatome slide, if you have an injury here, everything down is going to vasodilate, right? Causing what?
Low perfusion.
Low blood pressure. So what we're suspecting here is because he has an axial load to the head, he has a hematoma telling me that he hit his head. This is what his car looks like. His diaphragm's messed up, his blood pressure's low, and his heart's not compensating. This is a spinal shock. Does that make sense to everybody? Okay. And that's it. What questions do you have about this?
I wrote it down this time.
Okay. I'm excited.
So our book says, in resection, it's only from like 15 seconds.
Yeah.
You said when you were talking about how you just get unconscious and then just like, did you have to tell him to kind of like, tell him every 10 seconds like to move it?
If they're alert and they're trying to breathe, and they're just sitting in their mouth and you can like feel it moving out. That's what it feels like for them. Suction. Sometimes I've been ran into situations where I'm like, okay, that's suction.
Yeah.
But they know.
You would get me that
their
one.
face
Now you're the
is
hospital.
I mean, we had a 14-year-old, 15-year-old that was shot in the face.
Yeah.
And same thing with him, we just handed him suction, he just sat there the whole way to the hospital, suction, mouth out.
So that 8 to 10 seconds, does it not matter in like a conscious patient?
Honestly, the 8 to 10 second thing is really to help with your conscious to ventilate them, right? And so if you're like suctioning them out and you're watching their oxygen sats drop, right, you don't want to just keep suctioning them out. Same thing with us. Whenever we go to intubate people, we're supposed to do it within a certain time frame so that they don't de-oxygenate. So that 8 to 10 seconds is supposed to be kind of a conscious minded thing that you don't over suction them and forget, oh crap, their oxygen level is taking. I need to do that.
So what would you do if they're like not, if they're bleeding and it's not stopping? Like, where would you find the doctor to do ventilation for them? Or like to do the suction? Do like back and forth thing?
Pretty much like you're at that point on an ALS probably but in a BLS scenario, that's just like you're gonna use your best judgment. So you wanna oxygenate them, get them, watch their SpO2, get them oxygenated, but if it's imposing oxygenation that much, you should be using airways like airways. And then just suction them and wash
Kind of
fire.
going on the vitals?
Yeah, it's just like your best judgment in a scenario. If they're bleeding out that is their airways, that's definitely like, yeah.
It's kind of hard to say because I've had, patients that were like that have like filled up non-rebreathers where I'm like pouring them out, trying to suction them, stick it on their face, freaking spit blood, pull it off, suction them, stick it back on their face. So it's kind of weird, right? Like you just have to kind of use your best judgment in that state, that situation, to kind of cycle back and forth between the two.
And sometimes, like, what I've done, if they have really, really bad ears,
I gotta go talk to them.
I'll put them on like a high flow cannula, I'll put the needle cannula on, I'll crank that up. And I know it's really going to sit, I'll crank it up just so they can get like some kind of blow by while I'm suctioning, and then you go back to bagging or whatever you're gonna do. But like that, you're gonna find out that in medicine, most of the time, the answer to every single one of your questions is on. And there's like different avenues.
You got one more, right?
Yeah, it's only 11 slides.
Who here has already got a test prep website of some sort? Okay, so you guys are in, have you guys? Come on around, get one.
There's like 90 of them.
So listen, statistically, it shows that those who do test prep have a way higher pass rate. And on the thing, like when you go to their website, it'll give you their pass rate on there. So when we're done with the bulk of our learning, right, after that, it's all test prep, hard. If you don't start, you're gonna be behind the 8 ball, right? I'm telling you, if you don't get it, the odds of you failing are high. So you need to get it and start getting into it. And what I would do if I was you guys is I would take, because we're gonna have you do test prep on the Tuesdays and Thursdays, I would be taking full simulated exams at least twice a week. And then in between those days, I would be taking whatever you're low on. So if you have medic test, it'll tell you, you suck in OB, you suck here, you suck here. Well, if you just do OB or trauma or whatever you're low in throughout the week, it'll start filling in those gaps for you. If you get a question wrong, then you can go back and bring it to us and it'll give you an explanation. But if you want a different one, we can tell you kind of what they were thinking, right? You should have taken like 200 plus tests before you ever go into your test day. So don't procrastinate it. I understand it costs money. I understand we've all been there. I spent a bunch of money on it. I would get at least 2 of them so you don't just go through the test bank and you can and keep getting the same questions. At least that's how I would do it. Listen, I'm not the smartest guy in the world. I was a D student. I'm pretty damn dumb. I passed National Registry 3 times. Not because I'm smart, but because I did a bunch of test prep.
I'm gonna run over to the house real quick with Lucas.
Okay.
You got your,
Love you.
I'll be back.
I use, right now, PLC prep. The Audible one that has this fucking, it'll list off 4 different solutions that he's doing the test. As it goes, like it'll be like, this is the question.
Medic test, EMT prep, the liver one. Brady Lab has one that we're going to run you guys through. In my opinion, it's medic test. Medic tests. With an S on it.
I'll show you a little bit.
Keep pressing it. You keep pressing. I'm going to press back with you.
Yeah, they have like 3 that look so similar, so
Medic
I would
tests.
make sure it's that one.
Yeah, if you want, come find us and we'll like help you get established with it. And so this is what I expect, right? I want you guys, when you come in, to show me your tests. And I'm telling you right now, if you're not taking them, I don't expect you to pass. Right, like that's it.
I have a question. So what do like Tuesdays and Thursdays look like while we're in that like test prep? Do we come here and we can open our own program and we're going through our tests, or do you guys have your own?
So we're gonna buy like a subscription to it and then go through it with the class. And so we can all just kind of go over those questions together and troubleshoot and kind of like see how to review those questions and how to read those questions. So hopefully as a group, and then Brady Lab also has an NREMT mock test that we can put y'all through. We're trying to figure out exactly the specifics of it, but they are listed like as an NREMT test prep over OB or whatever. So we're gonna start assigning those to you guys as well.
So if you guys all take these tests and then 60% of you come back and say, we're all low in OB, then we can cover OB as a class. But we're not gonna be able to tailor it to every single person. This is something you're gonna have to do on your own.
And if you do have anything that you're like specifically like, oh man, I'm really bad at, operations or whatever, you can come to us. Like, we're here every single day, all the time. And if we're not, if you send us a text message, we'll be here. So if you guys have anything specific that you need help in any area, feel free to reach out to us because we're more than willing to come in and help y'all. So.
Yeah, definitely hard.
Yeah, I feel like this consensus of what I've gotten from y'all so far is like, we're doing well, except for an OB and EMS, like ops and stuff, and then we just haven't covered that stuff yet. So OB was hard for me when I was doing my EMT basic, when they had the adaptive testing. I'm pretty sure that's all my national registry test was for my EMT basic, was all OB. They're like, you suck.
Pregnant people suck.
Yeah. Yeah.
It's hard because they're just different. Physiologically, they're different. Their emergencies are different. Their anatomy is different. Their vitals are different.
I walk around with an extra liter of blood for crying out loud.
Yeah.
Yeah, they're growing a whole new organ.
They got that thing where they're like aliens and shoving things out of the wazoo, dude, that breathes life.
Yeah.
It's crazy.
Yeah, it's wild.
I feel like everybody sucks at OBGYN.
I feel like there's a lot of people that do, yeah. Actually, one of my nurses, when I was doing my exposure stuff in Atlanta, she was like taking my vitals, and I asked her how she, like, where she worked before. She told me she worked on the OB floor at Grady. She said she had a lady that delivered her baby and then went into like a postpartum psychosis. Started speaking French, never knew French before, was speaking French, didn't recognize her baby, didn't recognize her husband.
No.
I'm like, if I run into that.
No, that lady was possessed. That lady was greased and
Yeah.
probably to be drowned in some holy water. You hold her down there until the bubbles stop coming up. They've been fixing that.
Yeah,
That
she
lady
came out of it, but
was possessed.
yeah, it's wild. And like amniotic embolisms, scary crap out of me.
That's when you should throw the baby and the mom away. You just never know.
Yeah.
Right, calm down. Calm down.
Yeah. Wait till we start learning about explosive births. Listen, you're told like if it's wet, sticky, and not yours, don't touch it. And then everything about OB is wet, sticky, and not yours. And then don't touch it. But I want to. Sneaky. Yeah, that's a Jenny thing. If we deliver a baby around here. All right, so we're gonna power through this real quick. Multi-system trauma. Make sure that we're still recording. This is so short. Like I said, I don't know why they made this a whole chapter. It could be incorporated in any of the last 5 chapters. But we're just gonna cover some things real quick. So, define what a multi-system trauma consists of. It's kind of in the name. So hopefully y'all got it down by now. Learn how to manage the multi-system trauma patient. So obviously this is gonna be a dynamic management of your patient because if it is a multi-system trauma, it could be different systems. So there's no one good way of being like, treat them like this because it could be 2 totally different systems involved. And then criteria in how to identify high priority patients. So there is a little scale that's in your book. We're gonna review it. Do I have it memorized personally? Not even kinda. Every time I've ever had to use this criteria system, it's been pre-put into my charting system and I can go in and click some boxes and it gives me a number. So I've never worked for a place that actually needs that number for anything, so we're still not talking about it. All right, so multi-trauma patient is a patient with more than one serious injury. Then you have a multi-system trauma patient. That is where their injuries are different systems. So more than one, serious enough to affect more than one body system. So everybody knows that little body systems part of your little medical sheets, right? Whenever we're talking about this could be like burns, which is integumentary, right, with a broken femur and pelvis, which is musculoskeletal. So it's talking about multiple different systems involved in one patient. The biggest thing for these is a lot of times with your multi-system trauma patients, you have more than one patient as well, because if it's a burn, if it's a house that burned down, if it's an explosion, if it's some kind of like terrorist attack, anything like this, most of the time you're gonna have more than one patient with this. So the biggest takeaway, we're gonna get into triage in one of the later chapters, but teamwork, timing, and transport are key to proper management for these patients. So if it is a triage situation, to get them triaged appropriately, to have the right people telling the other people what to do, because like if it's an incident command situation, like Chaz is way better at projecting his voice and being like, you go here, you go here. I'm like, hey guys, so that's usually how that plays out. So if you have the right people, the biggest thing is like, if you work for a system that has the possibility of running a call with multiple patients, that you run scenarios, you go over roles before you even get on scene, before you even dispatch to the call. So this is where our training comes in. So most critical decisions, this is where that patient priority comes in. Whenever we start triaging patients, we're going to go over how to identify high priority patients. You guys went over it a little bit in the last chapter. It kind of differs a little bit whenever we get into triage, because triage, we're talking about treating the most people effectively as you can. So if you are like stretched thin on resources, that's where this comes in, your patient priority and severity. And then, are you going to spend time on scene? Are you going to transport them out? What are you going to do to treat this patient? And then closest, most appropriate transport decision. Around here, we don't have a whole lot of options, but if we were to run something with like multiple patients and we need to shuffle some here to Battle Mountain because they're minor, like minor injuries, or fly them all to Renown because they're all major injuries, those are all things that need to be made on scene, those decisions. So determining severity, we go off of a couple different things. So we have like physiologic criteria, which is these signs and symptoms that you're going to see. So altered mental status, if they have hypotension, this is all stuff that you can see on the outside, abnormal respiratory rates. And then you have your anatomic criteria. So this is like what, I guess you can also see this stuff on the outside, but in my brain there are two different things. Vitals that you obtain, and then this is like physical things that are wrong with the patient. So amputation, proximal to wrist or ankle. What does proximal mean? Closer to the body. Yeah, so amputation, if it's just the wrist, it's one thing, but if it's proximal up here, they're going to be a higher priority. Same thing with the ankle. Pelvic fractures, big problem, right? Why is that such a big problem? Yeah, lots of blood in a little area. Open or depressed skull fracture, that's going to be a high priority, obviously, because we can't do anything to fix that. Paralysis, penetrating injuries to central and extremities proximal to the elbow and knee. So if you're above here with a penetrating injury, or above the knees, or anywhere in the central area, that's a high priority patient. Chest wall instability or deformity, that's affecting the respirations, their breathing, their airway. That's going to be a high priority patient. 2 or more proximal long bone fractures. So if they have 2 bones broken in the same limb, that's a significant mechanism of injury to break both of those bones. So multiple bone fractures, that's in general a specific mechanism of injury, a very high priority patient. And then crushed, glove, mangled, pulseless extremities is another major one. What if you roll up and their arms facing the wrong way and they don't have a pulse? What are you going to do?
Try to get it back to anatomical position.
Yep, you're going to try and put it back to anatomical position, and you're going to check what? Pulse. Yep, good. All right. So, in absence of these here, MOI is considered if it is severe. So we're going to look at what caused the trauma to our patient. Was it a blast injury? Because blast injuries can cause a lot of internal damage that you can't see, but that patient may be really messed up. If they're tossed off the top of a building, that's a significant mechanism of injury. What is it? Falls greater than 20 feet or twice the height.
By the way, guys, everything here comes right off of the CDC Trauma Center criteria.
So these are important to note. Like your patient may look okay, but if there was a death in that same car, they are now a high priority patient. No matter if their vitals are fine, they're not altered or anything, as soon as you say, yep, their passenger was dead, they're kicked up. Ejection, what is intrusion? What does that mean?
That's how much it's into the vehicle or
Yeah.
whatever.
Yeah, so how much that car wall or whatever was intruded into the vehicle. Depending on where you work is how many inches of intrusion meets high level criteria. Where I used to work, it was 12. That's kind of what I go off now. So if it's 12 inches or more, that's significant. Even if it's on the opposite side of their vehicle from where they're sitting, that's a good enough impact to cause that much intrusion. They most likely have something going on.
Especially because cars crumple now, right? So if you got past the crumple and now you're intruding into the cab, the very, very, very high amount of force that it took to do that. The human body is the softest thing inside a car.
Yes. And then this vehicle telemetry data, I see this all the time, like in quizzes, test questions, in our charting system. I have never worked for a place that actually pulls telemetry data. So apparently there's a little computer that lives in the car and they can go in there and be like, yep,
That
this
sounds
was a
like
bad crash.
definitely
Yeah.
you're gonna be like transporting.
Yeah, I've never dealt with
Who's
it.
gonna be like, let me hook up the computer real quick and just.
Yeah. When I tried doing more research so I could give you guys more information about it, this is basically what I could find. So there's like something in the car that detects, kind of like in the airplanes, they have like those little devices that record everything. They send it up to a cloud, they can pull it and say, hey, this was that. I don't know if this has any kind of like relation to whenever we get called because of like the little, what would you call that?
Like the OnStar.
Yeah, like OnStar or like the iPhone crash alerts. I don't know if this has any relation to it.
But you all have everybody here has a device that transmits telemetry data, right? Your cell phones do it. If your cell phone is involved in a fast or hard enough impact, it will send out an auto alert to 911. We get probably 15 of those a year.
Watches, they do it too. You fall, fall detected, and then we'll get a call. All right, special considerations, pregnancy. It's always pregnancy in Iowa, every time. If you are dealing with a pregnant patient that got into a motor vehicle accident, ask them where they keep their seatbelt, because that's important. Because if they're keeping it over their top of their belly and they got into an accident, that's going to cause more damage. They do make these special little seatbelts. I don't know how effective they are, but they actually like clip between the legs. I don't know if they're effective or not, but that's something to keep in mind. Pediatrics are very susceptible to abdominal injuries from accidents because of where that seatbelt sits on their lap. And a lot of times, parents, they keep changing the criteria of like age and weight for these booster seats. I'm not even sure what it is now. I don't know if it's a weight or an age. This says age 12 and under.
I think it's like a combination of height and weight now.
Oh, is it?
Yeah, their feet can touch the floorboard and stuff like that. If the seatbelt can cross their chest like that without needing boosted up, then you can take it out. It's good to be.
Okay. Yeah, because this picture that I found, it like says if it goes over the shoulder or too close to their neck, then they need a booster seat. So yeah, pediatrics, they're susceptible to different injury patterns than adults. And then we always ask our patients that got in an accident if we take any kind of blood thinners. Are they on any anticoagulants? And then where I worked before, it's 20 weeks of pregnancy or more. So that might be like change dependent on where you work and your protocols, but usually around 20 weeks of pregnancy, they get kicked up to a higher priority trauma. So, like we said, it's always good to talk about your roles beforehand, whether it's in training prior to the call even coming out or on your way to the call. If you have somebody like a supervisor or an incident command that's already on scene, communication is key in these situations. So if it's like a big mass casualty incident, usually you have people starting to establish roles as you already get on scene. That's important to talk about with your partner too. So some of you guys that rode along, that went on our cardiac arrest, we had a general mindset of our roles and responsibilities before we even got on scene. Did those all go to plan? No, but everyone had a good general idea. And then determine your primary assessment and like what priorities they are, like what level of priority are you suspecting each patient. What is the golden hour?
Time from when the incident started.
So, yeah, from when the incident started to the time that they get into surgery. Not from the time that you got called or the time you got on scene, the time the incident happened to the time they get surgery. The chances of us getting a critical patient into surgery in under an hour living in Battle Mountain is pretty slim. But we can try our darndest to get those helicopters rolling before we even get on scene a lot of the time. Here's our little golden hour picture. So, general principles, some things you want to keep in mind if you're rolling up on scene like this. What's your first impression? I'll say avocado. What's your first impression here?
My guy's dead.
Okay, I like it. Jade? Jade, what is going through your mind?
Multiple patients injured.
Yeah. Okay.
You're gonna see all of the damage here, right? Like there is intrusion here. This whole front end is completely jacked up. Same thing on this one over here, right? The top of there is all bent in. That's a significant force.
Yep, so intrusion, we're looking at intrusion here. They definitely meet the intrusion criteria no matter how many inches you go off of in your protocols.
The guy's missing his whole front end. It's all.
Yeah, exactly. So scene safety is our number one priority. Obviously, you can kind of see that in this picture, they have the whole road blocked off. They probably have it blocked off on the other side too. But in these scenarios, if we're gonna go over this like a little bit further in the chapters, like if you're parking an ambulance and you have fire trucks and police officers parked, you wanna pull in front of them because if anybody comes, they're gonna kind of block whatever's gonna hit you guys. So they're protecting us. Thanks, Bill. Limit scene treatment, so we want to try and keep our scene time less than 10 minutes. Again, that changes to where you work. So like around here, if we're flying somebody out and we have 45 minutes before the helicopter lands, we have a little bit of wiggle room with this on-scene treatment, but we want to try and keep it as short as possible. C-spine, ABCs, treat for shock. How do we treat for shock?
Blanket, oxygen.
Yep, supine, keep them warm, oxygen. Restrict spinal motion, and then life over limb when necessary. What does that mean? We talked about it a little bit at the beginning of class.
Treat immediate life threats before.
Yeah.
Less than life threats.
Yeah, so if they're stuck in the car and they're not breathing and they're bleeding out, I'm gonna move them out of the car. I'm not gonna be like, oh, somebody hold C-spine while I need them out of here to address these issues. That is life over limb. And then pediatric patients, they will need additional emotional support. So if we have a certain provider that works here that doesn't do so good with kids, if you have a patient provider that's on scene that's a little bit better with kids, sometimes it's good to stick them with them. Because if you're standing over there like, they're there, you're not gonna help them out. But that's a big part of this, like anytime we deal with pediatrics, keeping them calm is helpful, right? We talked about like the epiglottitis thing and keeping them calm, even situations like this.
Joe's the best with kids.
Right.
Are you?
No.
All right, so.
Child is always touching.
You like stiff arm when kids That's funny. All right, so this is that revised trauma score that I was talking about at the beginning of class. I don't have any of these memorized. If you work for a system that uses this, a lot of times you get some kind of referral sheet like this, or it's in your charting system. It gives a numerical data objectively to how severe your patient is. So it factors in GCS, the blood pressure, respiratory rate, and then there is like a pediatric revised trauma score as well. And that goes off of like their alertness, all that stuff. So keep a high index of suspicion. If you look up and you see the car like you saw on the last slide, you're like, ooh, that's bad, and the patient's just walking around just fine, you should still be suspecting major injuries, multi-system injuries, and multiple types of shock. So keep in mind that our patients can have multiple types of shock. One of the scenarios they gave me in paramedic school was a dude that fell out of a helicopter. His parachute didn't open all the way. He landed in a field and got stung by a bunch of bees. So he was in anaphylactic shock, hemorrhagic shock, spinal shock. He was in all these different kinds of shock.
That guy has the worst day. It was like awesome.
Yeah, she was trying to bully me is what was going on. And then remember that pediatric patients don't compensate as well. So adults compensate, we go off of blood pressure, right? Kids, you're gonna be looking at their heart rate, you're gonna be doing the skin signs assessment, their altered mental status. That's a big thing, because kids are not just little adults. So you're gonna hear that a lot, and then usually my question to them after they tell me kids aren't just little adults, but what are they? Because they present so differently. So they kind of have like their own little realm of how they present. And yeah, what questions do y'all have on that? No questions. Alrighty. Well, we have 30 minutes. Do you have anything? Okay, no. We kept y'all a little bit late on things.
I mean, they should have a task to complete before they can leave class.
Okay. Y'all get ready for your task. But I
Alright.
don't have anything else for y'all, so.
Thanks, Austin. Let's clean
Yeah.
this up. Hey.
This guy's like, I can't. Test for the two from Austin.
The test from today.